We're excited tonight that our speaker is Dr. Lucinda Bateman. Dr. Bateman received her master's degree from BYU and completed medical school at the Johns Hopkins School of Medicine. She then completed her residency in internal medicine at the University of Utah. Since 2000, Dr. Bateman has specialized in the diagnosis and management of ME, CFS, and fibromyalgia. She is truly exceptional and is a recognized expert in these debilitating and disabling illnesses. She continues to work hard to help not only her patients, but for all of those who have these illnesses. Tonight, Dr. Bateman will share with us strategies for bringing doctors up to speed on ME, CFS, and fibromyalgia. Please welcome Dr. Lucinda Bateman.
Okay, well, thank you. It's a pleasure to be here. It's a big shift to go to a live Facebook program after teaching a class, which was very fun and interactive, and it was great. So I'll have to put on my little more official hat. It it was a little bit difficult to decide, how to spruce up this talk because it sounds a little bit like a boring topic, but honestly, if you look at the field, the two most important needs in the field of ME/CFS and also fibromyalgia are research and having clinical access to clinical care, doctors who understand these illnesses. And, we know we want to push for research, we need more research, but honestly, we just can't make any progress until we get all the doctors on board too, because that's how people get a diagnosis, that's how people get referred into research, and that's what the interplay of the clinical and the research is really what moves the field forward. And in a way, that's what we're trying to do at Bateman Horne Center, is bring that balance of well-defined patients in the clinic and the research and seeing what we can do to facilitate moving this forward. But we also have a commitment here at Bateman Horne Center to facilitating much more rapid transfer of information and bringing as many physicians into the field as possible. And physicians are usually great people. They're out there, they're spending their life helping people, they work long, hard hours, and genuinely want to help patients. How could these conditions, chronic disabling conditions affecting 5 to 10 million people that cost the US more than $20 billion a year, how could these illnesses be overlooked all this time, and why? These are medical mysteries. These should be the things that doctors and scientists are most interested in learning about because they're right on the forefront of medicine. So how did we get to this place? I think if we can't identify the problem, it's hard to solve the problem, right? So I want to start by talking about the barriers. How did we get to this place? Well, first of all, these illnesses, at least for many years, were thought of as not having any objective markers. No lab tests, no x-rays, nothing we could do to sort of prove the presence of illness. Honestly, the case definitions we've used, they were all well-intended, but they've been very confusing for clinicians. And when clinicians can't figure out what to do, it's hard for them to implement. The lack of objective markers means we have to spend a lot more time talking and communicating and to figure out what's going on with the patient. But the cost of medical care has gotten higher and higher, putting pressure on us to be more efficient, less expensive, more uniform, and still deliver quality of care. And with that has come an increasing reliance on objective tests and technology because talking takes too long and it's not as precise. And the whole field has been severely impaired by inadequate research funding. I just have to say that all of these things combined together. This illness complex, I think, was more low priority because there's always been a focus on illnesses that are fatal or rapidly progressive or contagious that may, and because this is a smoldering chronic illness complex, I think it's been less high priority. It's not an illness that's obvious. Using the standard methods that doctors use to take a history and do a physical exam. really we have to teach them a little bit different paradigm. And doctors don't know, really, they're not really trained how to query functional capacity. How is this illness affecting your function? They don't ask about orthostatic intolerance. It's difficult to have a conversation about the nature and extent of pain, fatigue, cognitive impairments. I mean, it's kind of funny because the more cognitively impaired you are, the harder it is to communicate. And then you just frustrate the doctor, right? And they just think you're being something different than the fact that maybe the cognitive impairment and cognitive fatigue is the problem. But most of those things get just overlooked in the current methodology and the way that we practice medicine. Medicine is super specialized now, and ME, CFS, and FM, they don't fit neatly into any specialty. And that has created a problem, and it hasn't been that long since medicine was less fragmented, and there was much more emphasis on primary care. It's become so fragmented that doctors work in different silos, and the other thing that comes out of that is we speak a different language almost. We might be talking about the same thing in different specialties, but we don't use the same terminology, and sometimes don't even know we're talking about the same thing. And there's been less and less support at the primary care level, and this has squeezed out a lot of primary care doctors who like to take more time to think, problem solve, look across multiple systems. And there's been a great deal of disincentive for doctors to not spend time with patients and not do things that, or I should say incentives to get them to spend less time and be more efficient, and almost maybe punished for taking too long or doing something outside the box or ordering too many lab tests or doing something that's not already standardized. We've had trouble meeting the standards of what's called evidence-based medicine. And I want to talk about that for a minute. And this is too long, but you might want to read it a little bit. But evidence-based medicine is an approach to medical practice that was intended to optimize decision-making of doctors. We wanted to train doctors, instead of to just wing it, but to, when a case is presented, to go to the literature, right? To go to research and to look things up and to use evidence to guide their treatment. But I have to say, and there's an emphasis, it has become more and more so, that we don't trust evidence unless it is considered strong evidence. And strong evidence is evidence that comes from meta-analyses, systematic reviews, randomized controlled trials. In other words, thousands of cases. And you can see these now in the literature. There's a big emphasis that somebody, instead of doing their own research, will review all the research in one area and bring it all together and judge those, whether it's weak or strong evidence, and then write a paper about how much we really know about something based on strong evidence. Well, that's a little bit of a problem when you have a new illness, and you have an illness that's underfunded, and an illness that has confusing terms. So we've got a couple of decades without the ability to build the kind of evidence base that is respected. And not only that, that's why information about ME, CFS, and fibro is not even strong on medical curriculum and on board exams, because the evidence base is not considered strong enough to be included. So that emphasis toward only teaching evidence that has a strong, that is considered a strong type of evidence has pushed and marginalized these illnesses further and further away from the evidence base. We don't have any treatment guidelines in fibromyalgia or chronic fatigue syndrome, and that's because treatment guidelines must come from strong evidence. Evidence from meta-analyses, evidence from systematic reviews, randomized controlled trials. So we have doctors out there who aren't taught about these illnesses and who can't reach for treatment guidelines. Those of us in the field who have tried to create resources for treatment, we have to call it something different than treatment guidelines, because treatment guidelines are now considered a very standardized and high level of information. If you don't have that information, then you have a void. And what we've had is a very long void. And I mean, this is like anything else. It's well intended in the beginning. And the use of a strong evidence is very important because that leads us down a path of making more correct decisions about interventions or making a diagnosis. And it's just kind of ironic that it's come back around to bite us and to exclude us. So let's go back about some of these barriers. I can tell you that the high costs of medical care are not going to change. They're probably going to get worse. There's going to be more pressure to be efficient, less expensive, uniform, and still develop quality. That's okay, though. But that is not an area we're going to be able to make a lot of progress in. However, what's very promising is we now are very close to having more objective biomarkers. And we also have improved case definitions, and most specifically, the Institute of Medicine report published in 2015 that outlined evidence-based clinical diagnostic criteria. This is for ME/CFS. This is a report that will be that meets those standards of strong evidence-based, or at least close. And that's going to make the case definition much more usable, and it will be used more often by clinicians. I think we're developing tools in the field to facilitate communication as a subjective part. And one of the things we want to do at Bateman Horne Center is provide some of those things for physicians. For example, the fibromyalgia impact questionnaire. It's just a very brief questionnaire. Patient can fill it out, and it provides a great deal of information about how pain impacts people's ability to function. And a picture's worth 1,000 words, and that those scores can be interpreted and can facilitate more rapid decision making. And then the last one, we now have research funding, and it will be coming, and it will be coming more. We have a commitment from the director of the NIH, and we have support throughout the agencies at the NIH to improve research funding for ME/CFS and fibromyalgia. There's such a big overlap between these illnesses. Whatever happens with one will benefit the other. So that's positive. There's really only one area on these barriers that is going to stay. So we're going to have to get used to that, and instead of having it be a barrier, we're going to have to use it to, what we do want more technology, right? We would like medicine to be less expensive and efficient and higher in quality. So what about the second page of reasons that our illness got marginalized? We talked about low priority and all of those things, and there's one on there that's not going to change, and that's that medicine is going to remain super specialized. There's no doubt about it. It's going to get more so. And I don't think it will happen very quickly that ME/CFS fits in any given specialty or fibromyalgia. There's still going to be no medical home. What we need to do is we need to empower primary care providers again, because primary care providers take care of the whole person. This is a multi-system illness, and until we've got more of a magic bullet, it's critical to have a provider that takes care and organizes and helps manage the whole patient. So we're going to do as much as we can to focus on helping primary care providers feel more comfortable managing the illness, because we're not going to be able to change the fact that it's very super specialized. So what else? What has changed? Well, we now have priority. We're not low priority anymore. There have been many strategic changes at the level of the National Institutes of Health, and at least on the federal landscape, fibromyalgia and chronic fatigue syndrome are up and very high priority in every way. I can tell you that if we can train clinicians, a standard history and physical exam can be altered slightly and pick up cases every time. And all we need to do is be able to teach clinicians about what to look for in history on a physical exam. And we are much closer to meeting the standards of evidence-based medicine. We have had Well, the Institute of Medicine report is going to be a good evidence-based medicine document. There are efforts to create, instead of individual small research programs, the NIH is funding, there's money coming to fund collaborative research centers so that all of the data can be combined, that the data will be, try to be more uniform in the way it's collected and stored centrally so everyone can use it, and that larger numbers of patients will participate so that at some point we will have much bigger numbers and we're going to start to reach that level of strong evidence, and hopefully sooner than later. And one of the things we can do at Bateman Horne Center is facilitate that, and that's part of our goals. This is, I pulled this list out of a talk I gave in 2014 after the IACFS ME conference. And I listed, I changed it just a little bit, but I listed the areas of medicine where we really have the least resources, right? They're more frontier. We have fewer lab tests, less knowledge, less information. And unfortunately, our illness falls squarely in this list of places where we just don't have as much, let's just say, if someone has heart disease, you can practically do anything to fix it. Our ability to take care of heart disease is so advanced. But the problem is, the areas of viruses and treatment for viruses, if it's not on a transplant patient or an HIV patient or something that relates to that, most people just recover from their viruses. So there's no motivation to develop extensive testing and treatment for viruses. We have relatively rudimentary understanding of the immune and inflammatory systems, including the gut and especially the central nervous system. We don't have much ability to query and assess the neuroendocrine system, which is basically your hypothalamus and your pituitary and the way it controls the rest of your body. We have a hard time studying the brain, the autonomic nervous system. We're coming along in terms of using genetics and gene expression and epigenetic factors. And we really are very rudimentary about the effect of environmental exposures and nutrition, and of course cellular metabolic defects. So these are all areas that I listed back in 2014 as, the answer has to be in these areas that we don't know very much about. Otherwise, we'd know about it already. But the cool thing is, a lot about the understanding of our illnesses has changed just in those 3 to 4 years. We have lots of progress in these areas. But it's still a weak area. We lack diagnostic tests and established treatments in these systems. But most of all, illness in these systems is beyond the general training of most physicians. So when it gets in this realm, they don't know what to do, and they don't have the tools to do it. And they'll send people to specialists, but there's still defined areas of how much they can do in the clinic. I think everybody's experienced that if you go to infectious disease, or you go to an immunologist, or you go to a neurologist. Very few can offer that next step about understanding what's going on with our illnesses. So we have a lot of work to do, but it's possible and things are moving along. And I think that it will be critical to move this along as fast as possible into the hands of doctors. So here's another barrier I didn't really think about for a long time. So who's in charge of deciding what we should do in medicine? I mean, who's the boss of medicine and science? There really isn't anyone. It's a lack of organized, it's not a hierarchy at all. And so we have hospital systems, like freestanding hospitals. We have medical centers that are hospitals where we train doctors, medical school residency fellowship. We have we have research scientists who gets PhDs. We have medical journals where there's a big hierarchy, but if something gets published in a very prestigious journal, it's like the Bible, right? It gets added to what we do in medicine. A lot happens on the federal level at the Department of Health and Human Services and in the NIH, but they're not the boss of academic institutions. They have their own internal system. They do regulate policy, and they have a big role in funding academic researchers. So there's interplay between all of these organizations. How about accreditation and licensing boards? they have a lot of control over what people have to learn and how they have to show performance. Professional associations like the American Medical Association, the Utah Medical Association, and there's an association for every specialty, many, and that little TNTC means too numerous to count. That's a microbiology term. Insurance companies dictate what we do in medicine now more than ever, and nonprofit organizations like Bateman Horne Center. And the reason nonprofit organizations exist is to do something that can't be done in those systems. And the Institute of Medicine that did the evidence-based report for the for the MECFS clinical diagnostic criteria is a nonprofit organization. And the NIH institutes pulled together $1 million and offered a contract to the Institute of Medicine and paid for them to do the evidence-based review and do this huge amount of work over a year with experts to come up with those clinical diagnostic criteria. So how do you approach a system like this? You can see why it's difficult to make change, particularly when most of those are entrenched in what's now considered evidence-based medicine, which is only strong evidence can be published, can be taught. So we've got some work to do. One of the best things is that the federal agencies are now on board. They're doing everything possible to move this field forward and to provide education, but they don't have very much control over practicing clinicians. And that's one of the reasons there's a huge void. Academic medical centers are among the most stringent about only teaching evidence-based medicine. So there's been a large gap. And in the 10 years that fibromyalgia drugs were developed and marketed, the gulf between the knowledge of academic physicians and physicians in the community for treating fibromyalgia became very large because the drug reps could go teach in the community but could not talk about their drug and thus teach people about fibromyalgia in academic institutions. Because of the tension between pharmaceutical companies and academic medicine, sometimes the reps from drug companies are not allowed to even do anything, talk to any of the residents or the medical students. And I understand, I'm not judging, I'm just saying this is a situation that's kind of complicated, and there are reasons why these gulfs are very large. The professional associations, they don't actually control how the way medicine is practiced too much. I mean, all of these areas have influence, but it's not a hierarchy. So where do we start, right, in trying to establish a plan about getting the right information to physicians? In Chapter 8 of the Institute of Medicine report, and I haven't footnoted this here, but it's called, I'm not going to be able to remember the name of it, but it's a very good, long, evidence-based report saying what the major presenting symptoms are of ME/CFS and how we should use those to make the diagnosis. But there was a whole chapter at the end of dissemination, is a plan. How can we take this new information and get it out to doctors? And one of the statements in there was that the existing barriers are mostly attitude barriers, not knowledge barriers. And that doctors still, if you poll doctors and send out questionnaires, and these were done through some of the CME activities on Medscape and other places, doctors express doubts, misconceptions, stereotyping, still old thinking about the illnesses being related to mental health problems or personality traits, that it's not really a distinct entity, that it's just a garbage can diagnosis, or that it's too difficult, or even that diagnosing it won't help people. It'll make them sicker, right? It will label people, and then they'll get more sick behaviors. And overall, when polled, the MDs have low self-efficacy, they lack expectation of a positive outcome, they think there's nothing that can be done, so they're not motivated, and they're just not confident about making a diagnosis. So this is a big hurdle. And of course, the term CFS, especially chronic fatigue syndrome, causes perceptions that the illness isn't really serious when it is. It's the most serious in the illness spectrum when people meet ME/CFS criteria. And also in that chapter, they outlined who they thought the targets of the educational and dissemination efforts should be, who should be the targets. And right at the top of the list, all the primary care specialties, and then people that are frequently, that are people with fibromyalgia and ME/CFS commonly encounter. Of course, OBGYNs are primary care for a lot of women. Emergency room doctors, mental health providers, the common referrals, neurology, rheumatology, GI, sports medicine, sleep medicine, cardiology, rehabilitation medicine, pain specialists, et cetera. So across the board, we need to be able to reach out to these doctors. And of course, the rest of that list is really important. But that's not our first priority, and that's not what we're talking about today, because we're going to focus on physicians. So physicians are educated, basically, in medical school and residency training. Then they get board certified, and usually have to recertify every 5 or 10 years, depending on the specialty. So those are opportunities to insert the appropriate kind of education to make sure that doctors are being trained. They also learn through continuing medical education. So these are courses that have to meet a certain standard on subjects, and doctors are required to have a certain amount of continuing medical education credit in order to be on a hospital staff or to maintain their certification. And then there are more informal ways that doctors learn, over lunch and bringing people in. And but the top 3 are the most key targets for making a difference. Well, right now, I think it's going to be the most difficult to change the patterns of medical certification, recertification. But that is a route that can be useful. But we really need to develop strong conversation and ties with academic medical centers, so that the faculty members, who are great scientists and clinicians and role models for students, can to begin to understand and teach about these illnesses. And then, of course, we've been at work a long time trying to find a way to do continuing medical education. But we had a brilliant CME program a few years ago. It was a half-day program on ME/CFS. We had the head of the CFS research at the Centers for Disease Control. We had a behavioral specialist with years of experience in the field from Stanford. We had a neurologist from Harvard who came and talked about her original research in small fiber polyneuropathy and how it was probably an organic basis for fibromyalgia. And I mean, we had like this program of 4, there was one more person. Oh, it was Alan Light talked about gene expression and his groundbreaking research at our very institution. And we couldn't get internists and primary care doctors to attend. It was a fantastic program. It was well advertised, and because those stereotypes are still there, we had a pretty good audience because we tried to pull from PAs and nurse practitioners and mental health providers, and there were a smattering of family practice doctors. But I did it through the Department of Internal Medicine at the university, and none of them came to that amazing CME conference. So not blame, but just a description of the barriers that we've just discussed. Attitudes, misunderstanding, so many barriers that have kept this problem going. So change must be accepted and implemented in every arena we've talked about. Those 2 things are important, right? Because if they're not accepted, if they don't, with open arms accept what we have to tell them, they're not going to implement it, and it's not going to be successful. So I'd like to talk to you about some of the things Bateman Horne Center has been doing and also hopes to do and increasingly do in the future. And one of our strategies, and this has been true for many years, is to try to build partnerships with the primary care physician and the patient in this triangle. So we have something to offer from our years of experience and our experience with research. We see the patient with ME/CFS or fibro in consultation, and what we want to do is loop that primary care doctor into the knowledge circle, have them understand what we're doing, and have them, partner with the patient to implement a lot of what we do. And I have a policy that I'll take a phone call from a doctor anytime who wants to call and talk about their patient. Because lots of people want to call and send their patients to our clinic, and I don't interrupt for those calls. But if someone calls and has a question about how to manage their patient, I will walk out of the room and whatever I'm doing and talk to them. So we want to be able to be available. We want to encourage patients to work with their primary care. It's awkward though, because it's not the way we've done things. You go to a specialist and they suggest things, they're in charge of that. And a lot of primary care doctors will say, well, that's not what I do, that's not my thing. But I really think we'd like to change that and have this partnership. The other thing is patients want a doctor who will understand them, and they don't want to be training their doctor. But I would like to say that every patient should be training their doctor. You should learn everything you can about the illness and partner with your primary care doctor, and the two of you learn it together. And then you have one more doctor who understands this illness and will start to help other patients a little bit at a time. The next thing we're doing at Bateman Horne Center, and we're just getting this started, our pilots, but we have set up an educational program for patients, particularly patients who can't get into the clinic, and patients who desire supplemental information who are already part of our clinic. But our first priority is the patients who've asked to come to our clinic and we haven't been able to get them in. So we have developed these 7, I think, it's a project in the making, classes on post-exertional malaise, pacing, sleep, pain, orthostatic intolerance, cognitive issues, coping. And between Dr. Drescher, who's a behavioral specialist and very, very experienced in managing and helping people live with these illnesses, and what I can talk about as the internal medicine specialist, we're trying to set up these classes so that people can come and participate in the class and basically learn everything we do in our clinic visits. They just take that information back to primary care or on their own, and we're hoping this will be a good resource for patients. We're going to expand on that if we can, so that we can also set up support groups that are led by a professional for people who like to work with similar, a men's group or maybe teens group, or maybe one specific for fibromyalgia, one specific for more severe ME/CFS, et cetera. One of the other strategies is we are going to embrace and use the IOM ME/CFS clinical diagnostic criteria. We're going to teach them every possible way. There's been controversy over every case definition, but I will tell you, we need to make it simple enough and have it make sense that doctors will be able to make this diagnosis. I think doctors are coming along with fibromyalgia. It's been kind of slow, but there's a much better understanding about what widespread pain is. But as soon as it gets more complicated than just the pain issues, then it starts to be, I think, overwhelming to physicians. So the IOM criteria are designed to put those manifesting symptoms front and center, so that the clinicians know what those core findings are and can start to look for them. And then, of course, the fibromyalgia criteria, and in every setting. And one of the things in the small print down there is, in our efforts to do research, we're trying to remain focused on the IOM criteria, so that we have an emphasis on how do you measure cognitive function, how do you measure orthostatic intolerance, so that we can develop tools to talk to doctors and empower them when people come in to be able to do something and to be able to measure it and know what it means. So the next few slides are the physician resources we have in development. This is what we're hoping to do and hoping to implement as soon as we can. And the first is, we have a website. It's been more of a patient-friendly website, and it links to our YouTube site, and we have blogs, but we'd like to put a section on the website just for medical providers that's very informative and concise, with either primary information or links to primary information. Diagnostic criteria, expert consensus treatment recommendations. Did you notice I didn't say guidelines? Treatment guidelines. There are some really quite good treatment guidelines equivalents out there but because they can't carry that label, treatment guidelines, they're a little bit harder for people to find. We're posting very specific instructions about how to measure orthostatic intolerance with a simple tool. We're going to try to link to questionnaires that can, they can, if they say, oh, my patient has fibro, oh, I'm going to go call up the Fibromyalgia Impact Questionnaire and print it off and give it to their patient so that they can have those at their fingertips. And I'd like to also connect clinicians through our website to all the progress that has been made at the federal level. The Trans NIH Committee, the Chronic Fatigue Advisory Committee, the CDC, and this is true for both ME/CFS and fibro, but they're kind of on separate paths. And then would love to have a place on the physician website that has key scientific publications, particularly those supporting the major presenting symptoms, so that we build that evidence base. And to have a place where we can kind of breaking news research, so that if they want to know what some of the new ideas are, even if they're smaller studies, they can see what's cooking. And that's what we hope to do in one-stop shopping on our website. We also plan, and this is a work in progress because we've done a lot of CME talks, but develop continuing medical education talks on the diagnosis and treatment aspects of this illness. And what's different is, I mean, people would sometimes call and ask me if I would do it, and I would, but we're gonna pound the pavement now. We're gonna have people on staff who are searching for CME programs and offer ourselves up and get on programs where people go to get their credits so that we can have a presence and start to get the word out. We'd also like to develop, and this is my idea, I'm not sure I've talked to everybody about it, but I'd like to do a Bateman Horne Center based CME seminar where we bring doctors here to this room, and we have a workshop where with a few primary care providers where we maybe spend 3 or 4 hours going through all the dimensions, like those classes about how to make a diagnosis and treat. And we also have a plan to, there's a grant request process going on right now at the NIH for a pretty good amount of money for collaborative research centers. And we are part of several of those grant applications. On one of them, we've proposed that we utilize a network that already exists at the University of Utah here and use that to identify physicians in the community who are interested in translational medicine and want to be part of clinical research. And what we will do, if we get the grant money, is create an educational program for those community physicians so that they become the ones who identify and diagnose patients and then refer in to our clinical trials. And that way we accomplish two things. I still got to stop saying about killing birds with stones. Anyway, I don't know where that came from. So I have a bird, and I don't want to kill him. Anyway, I think that would be just terrific. We have so many great resources here in Utah, and I know that's not the same everywhere, but we're developing ties with the Utah Population Database and with the Clinical and Translational Research Group that implements clinical trials. If we connect with them, when we have a potential drug to look at, we can enable that system and identify patients and send them in for research, and it will just be fantastic in moving toward a better evidence base. One of the things we want to do in training physicians also is to emphasize early diagnosis and treatment so that patients don't go on to develop worsening and worsening disease because nobody knows, how to address it or what it is. I think we may change the face of these illnesses if we can help primary care doctors identify the illness a lot earlier, including maybe getting the right tests at the early stages of illness so we have a better idea of what caused it. So those are all things that we can work on in the future. We want to provide guidance on how to make a differential diagnosis. I think doctors are a bit overwhelmed. If someone comes in, they've got a million symptoms, they're feeling horrible, and they don't know where to start, and they feel like they need to send to specialists. But hopefully on our website, we can put some guidance about, here are the things you need to think about if someone comes in with widespread pain and chronic fatigue. And the common and maybe some of the uncommon situations, and to be active at recognizing comorbid illnesses, other things that travel with this illness, and get confidence in making a diagnosis of ME/CFS or fibro. We want to pass on to these clinicians that there are lots of objective findings if you know what to look for. These are, you can demonstrate tenderness and trigger points and orthostatic findings and cognitive impairment and lots of subtle things on physical exam that aren't that subtle if you know what to look for, and findings on neurological exam that people just skip over because it's a little bit tedious. But really, and some of our multi-site studies are helping us understand what some of these, how to emphasize what to look for. One of my very sick patients finally got a diagnosis on biopsy of small fiber polyneuropathy. She's pretty classic ME/CFS patient, and that opens the door to all the specialists because we now have that objective diagnostic test that shows that her small nerve fibers are damaged. I put this on about lab tests. Lab tests are generally normal, but there are things that we're learning to look for, and particularly maybe some of looking to see if we can find the smoking gun, the trail of what happens in the first 3 to 6 months when people get sick. And there was just a paper published about cytokines, a paper at Stanford, and we may be able to develop a panel and look at some of those cytokine panels. Certainly we can evaluate sleep, we can do cardiopulmonary exercise testing. There are often findings on MRI and on spinal fluid. All of these have published data to support some of the abnormalities. I want to teach them. I think this is a little bit, but we want to try to approach this through, enhancing communication between the doctor and the patient by helping them know how to be more efficient, how to utilize questionnaires, and then and also by talking to the patients. Most of all, we want to use the highest quality evidence to inform, because the better evidence, you have to talk the talk, to understand the system. And if we want them to listen, we need to come to them in the way that they're used to listening. And fortunately, our evidence base is growing. And so one of the things we've really made an effort to do here at Bateman Horne Center is to partner with leading scientists to help facilitate their research. Lots of scientists have ideas and even money, but tend not to have patients and subjects. And the most difficult thing for them to do is to recruit patients into their clinical trials. We just have patients coming out the walls and don't do as much primary research here. So our strategy is to build this research-ready army, to have well-defined patients, and then reach out to researchers who are doing related studies and bring them into the field and say, look, if you can get a grant for this, we can give you 100 patients, 100 patient samples with all of their data. And that's been a very successful strategy in the last year or two. And then this is part of what will come out of the Collaborative Centers Grant, is to collaborate with other centers, develop multi-site studies so we have cumulative, much larger patient enrollment so that we can meet that standard of strong evidence. And I think that's the end. So I guess it's not that boring. And I hope there was something there to help you understand why we've had such a problem. And understanding the problem, we can go at it a little bit more strategically and see if we can hasten the progress and get, I think it'll be pretty catalytic once we get our toe in the door and get a few more published studies. All right, questions from the room or from Facebook? Yes. Yeah, so we're having a little mic issue today so that you're not mic'd, so I'm going to repeat the question. So our question is, were we aware of the story of an advocate who was able to get the health department to issue statements to clinicians about how to recognize the illness? Yeah, I mean, lots of things are happening in lots of places. Because it's such a complex system, we really ought to hammer at it from every viewpoint. And anybody who has a connection or an idea about how to approach and how to break down those barriers should start to do it. And because we now have the materials, we have the support at the federal level, so there's lots of information and research. And I think, as the Institute of Medicine report kind of filters down, I didn't really say this, but it's considered the top of the academic pecking order. So of all of the academic medical institutions, the Institute of Medicine is very, very respected. So that report, even though it's not the end-all and be-all, in fact, the report said, it should be revisited within 5 years. It shouldn't become, the standard for all of the future. But it's respected, and people can look it up. And so you take the information from that report. It's really great, by the way. Anybody can take it and incorporate it into public documents, or anybody that works for the feds or for the state. And it's considered the strongest level of evidence. So doctors can use it with confidence. And so we should utilize that and use it as a springboard.
So since there's no mic, I was going to just make a comment regarding this.
So, okay, come on up and stand next to me.
Okay. Well, I guess I should start out by saying I owe a special debt of gratitude to Dr. Bateman for mentorship in this area. And I hope that my education has been a little bit of the success of the center. But what I was going to make a comment and then ask a question. The comment was, I think it's very interesting that the point you made about the lack of a subspecialty, and this is something I've mulled over for a long time. And my own conclusion is it's appropriate that neurology is picking it up in the NIH, and that might have been my pick if there had to be one, but it's truly a systemic illness that doesn't all fit in there. And it's interesting that it's almost like you said, it's a general internal medicine, a general type of illness, and yet it requires a specialist who goes beyond the lack of the normal primary care area. And so I think that places it in a special position. But the question was, there are. My feeling has been that if you can get this into the medical school curriculums and the medical residency curriculums, that's where a lot of the attitudes are developed. So there are things like there's the MCSAP, there's the Yale ambulatory curriculum. It seems like if a larger organization like the IACFSME or something like that approached those, that we could get this inserted in some of those curriculums, and I was wondering if you're aware of any efforts to do that type of thing.
Well, there are some efforts, but to date they've been met with not very much enthusiasm, right? That those barriers are still there. We just need to keep chipping away. I'll give you an example. Is shortly after the Institute of Medicine report came out, I met with a mentor of mine up at the University of Utah who's a neuropsychologist, a really excellent clinician and researcher. And I just had lunch with her, and I said, this report is amazing, and we've got to promote it. We've got to let people know about this report. And so she arranged for me to meet with some of the neuroscience young faculty over lunch and talk about the report. And she also arranged for me to give a CME talk on these new criteria at the major regional neurology educational continuing education meetings. And it was a little scary, because I'm not an internist. I mean, I'm not a neurologist, I'm an internist. But I just gave a talk about these new criteria, and it was just welcomed with open arms. I mean, people came up to me, they were nodding in the audience, they said, we know who these patients are, this is so great, and can I refer patients? And I'm like, no, I want to refer patients to you. But anyway, it was just great, really great. And just this week, I got an email from another area up at the University of Utah in sleep medicine, asking if I could come give a talk on the sleep and how and the physiology of sleep in fibromyalgia and ME/CFS and what the sleep specialists might need to know. And this is just the beginnings, right, of those little doors opening and giving us a chance. And I honestly think that when you can have an honest discussion if you have, with physicians, they're going to resonate and respond with the data. So it's getting the door open. And in terms of, the doors are pretty rigid in these credentialing organizations, but I think we need to work on it. Yes. Yes, I do. So she said, her question was, does this super subspecialties and also this emphasis on evidence-based medicine, particularly strong evidence being the only thing we talk about, does it make it harder and harder for people to think outside the box? And the answer is yes, it does. So what we need to do is create crosstalk again, common language, pull things together, and I think it started. And it started at the NIH when they moved the illness into the agency that is neurologic research, and get those great minds thinking. And I can tell you that they're interfacing with patients, and that inpatient, they have an in-house NIH study for ME/CFS, so they're bringing patients in and keeping them there for a week, 2 separate times, and doing every test in the book, and it's changing lives. Because they're getting a chance to see the illness and meet the patients, and we have these great minds who are going to help us. So we can break them down, but it's hard. What we've got to do is inspire them, right? And impress them. So, yeah, I mean, the question is, where do we start? And that's kind of what I was trying to present today, right? That's the big question. And there's many ways, but it's sometimes as simple as a personal relationship, right? That you capitalize on, and you bring that person to the place where they can gain understanding. And when they do, they usually never are the same. So, and that's what happens when people come here and observe or spend time here and spend time with patients, or we bring in pre-med students and other people to come and learn from patients, and they go away, realizing. I'll just give you a quick example too, is I teach a class, not at the medical school, but at the PA school. And also we do at the nurse practitioner program. And my PA has been doing it. I've done it before, but she's been doing the nurse practitioner lecture, and I've been doing the PA lecture. That it's like this 3-hour, 2-hour lecture that covers the span of fibromyalgia and ME/CFS. And at the beginning, I always ask them, how many in here have, heard these illnesses or patients spoken of, in a derisive way or in a joking way, or saying it's not a real illness? And, literally more than half of the hands. And actually, I asked them specifically if they've had experienced it in their training, from their mentors in their training. And more than half the hands will go up. At the end of the lecture, they're all jaw dropped, and just full of all this information. And then they're kind of scared, and they say, can we refer patients to you? But, the whole idea is you got to scare them enough to know that it's real and substantial, but not so much that they're afraid, they're so afraid they won't be able to understand it. And I think that's part of it for physicians too. right? They're starting to understand that there's a problem here, and there's research and papers coming out, and they know nothing about it, and they don't know what to do. They don't know how to, what to do next, and what do we teach people to do is refer up, right? So people end up getting referred and referred and referred and referred because we're starting to recognize that it's a serious illness that we don't have answers to all the questions. But it's getting better, getting better. Do you want to come up to the mic?
Couple international type questions, actually. So the first one here is, can we coordinate Canadian patients and or test centers also?
Maybe, right? I mean, we've sent our samples to 2 different scientists in Canada. So we're at least crossing that border in terms of sharing information. There are some good systems in place in Canada, but it's pretty much the same problem both places. So the more we network, the better we'll be. And the more, each use our own avenues and skills to take the information where it needs to go, the better off we'll be.
Okay, here's another one. Since the CDC zeroed out our $5.4 million in funding again, are there any kind of programs you're aware of where physicians, organizations, etc., partner with physicians in other countries that might have better medication options to try, such as Ampligen, etc.?
So a question about, treatment away from what we're talking about today. Stop moving this around because it tends to go on and off. Because until we can join the ranks of medicine and science, it's going to be difficult to make progress with treatments. So the sense of urgency I have is to bring clinicians on board and mainstream us back into medicine and science. And then things will move a lot more quickly. So the answer is, yeah, I don't know how we can directly do that now, but that will be the outcome of following this path.
Down the road. Okay. Will there be
It's kind of on and off.
Okay. Okay, we'll repeat that. Will there be physician info sheets that can be emailed or printed for patients to pass on to their doctors? I've really appreciated the online video education and live feeds, but I struggled to transfer that info to my GP. Will there be ways to transfer this information to our doctors?
That is our goal, is to have the information for physicians. It will be open to anyone who wants to get on there, but the format will be a little different, more concise, something they can look at quickly, summarize, pop, click on a link, see a paper if they want to. And yes, we will have resources on there that can be downloaded. We have that on our website now, but we need to kind of change it up because it's hard to find some of the things on the website. For example, we have all the instructions and handouts for the NASA 10-minute lean test, which is an orthostatic test, which it was front and center, but as time has passed, it's kind of got pushed back. And if you don't know where to look for it, you may not be able to access it. But I've had a lot of patients just print it out, take it into their doctor, have their doctor do the test. And if their doctor's not sure what to do with the results, we can talk. And it's been very, very helpful in many cases for the clinician to get objective data about what's going on with the patient. So we try to expand that into the other areas.
Okay, there's another question here about the Marshall Protocol. Have you looked into the science of the Marshall Protocol, and what do you think about it?
That's a good question, but I think it's a little bit off track from what we're talking about today, so I'm going to defer on that. Any other questions about physician education and efforts? right? So it harks back to the problem, right? Is we don't have, no. We'll try on our website. She's wondering if there's a list, about who will be the most informed specialists and people who have gained knowledge. And it's a little tricky to do that. We've thought about that over the years because, first of all, you don't want to flood someone. You need to have a pretty good list up there. And then you have some responsibility. What is your responsibility for vetting that person, right? Or evaluating them when you recommend them. But we definitely want to work out a way that we can list, ME, CFS, and fibro-friendly clinicians, that have been recommended by other patients, for example, and try to get the list big enough that it gives people some options across the different insurance and in different regions. I also want to say that I'm so hopeful because it's not just neurology. From my position where we are here, I'm having great conversations with cardiologists. There's a GI specialist up at the U that is really interested in autoimmune diseases and irritable bowel and many things down that path. And I had a couple of calls from people at Huntsman about how to manage people in cancer treatment when they have a background, when they have an underlying illness of fibromyalgia and ME/CFS. So, more and more clinicians are trying to reach out and learn and take care of their patients. The biggest problem is I can't be the one. There's only one of me and hundreds and thousands of everything else. So I want to help in every way I can, but we need to multiply this, right? We need to get doctors accessing the same information I access to know what I know. And that's what we want to do so that there's a place they can go and things they can learn right away. So, but I'm hopeful. The attitudes are definitely changing.
We have no more questions on Facebook Live, but we have a lot of folks commenting on their appreciation for all of your hard work, Dr. Bateman. So thank you very much, and thank you very much for your presentation tonight.
You're welcome. It's great. Thanks you. Hopefully we can keep making progress.